sir. We are live.
Hello, good evening and namaskar. It's a great pleasure to welcome you all for Oncology Insight Forum Day 2. And today we have few more exciting topic for discussion, focus on the GI cancers and the GU cancer. This is done under the aegis of update in Oncology X. It's a pleasure to welcome and invite Dr. Shyam Agarwal, sir, Chairman and Head Department of Oncology from Sir Gangaram Hospital, New Delhi. Good evening to you, sir, and we request you to set the ball rolling with your welcome and introduction, please. Dr. Sham, sir, you there? Hello. So we can't hear you, Dr. Sham, sir.
Yeah, good evening, everyone, and welcome to the second day of this Oncology Insights. So yesterday we had a very good interactive and a learning session on several aspects of breast cancer, early as well as advanced or metastatic breast cancer. So we did have Dr. Shahina Dawood who joined us, and she shed a light on several aspects of HER2 positive, including HER2 low breast cancers. And then we had a great discussion on ER positive, metastatic, and early breast cancer. So I think it is day 2 today, when we are going to be talking about GU cancers, starting with prostate, going on to bladder and kidney, and then we have hepatobiliary sessions. So I think there are several newer drugs, newer advances, which are happening virtually by every fortnight or so. We really need to stay abreast with these new developments so as to advise and guide our patients in an appropriate fashion. So I think we look forward to the lectures and the interaction from the audience. And let's hope we take back home new learning points from these lectures and discussions. So with this, Tarun, will you invite Dr. Aditya?
Yeah, sir. So thank you so much for this kind introduction. And so the first topic, a very interesting one, the role of PARP inhibitors in prostate cancer. Pleasure to welcome and invite Dr. Aditya Sareen, Associate Consultant Medical Oncology from the prestigious Sir Gangaram Hospital, Delhi. Once again, very good evening and warm welcome to each and everyone. Dr. Sareen, over to you for your presentation.
Thank you, organizers and Dr. Shyam Agarwal sir, for giving me the opportunity. And Tarun, is my voice audible, loud and clear?
Yes, sir. You're absolutely, your slides are visible, you're audible. If you can be a little louder, that will be kind of.
Okay, so the topic which I have been given is current use of PARP inhibitors in prostate cancer, rationale and its key data. So let's start with the simple case. Now, this is our day in and day out practice. He's a 63-year-old male who was diagnosed to have high PSA in 2015. The biopsy showed a 4+3 pattern adeno, and he received ADT for 6 months and EBRT. Followed by that, after 1 year in 2016, the patient was having PSA of 3.6 once it touched the baseline. And obviously, once after that it had touched the baseline, it started to rise. So hence the patient had a biochemical recurrence. And then he was again, restarted on intermittent ADT. And in 2019, patient was till 2019, patient was doing well. Again PSA rose to 17 and the testosterone of more than 50. Again, imaging performed and showed evidence of the metastatic disease. And to begin with, it was an oligometastatic, and patient had low volume disease. And again, he was given with treatment with ADT and abiraterone and RT to the T10 vertebral body. So this was in 2019. And he's having a significant family history here. His mother was having ovarian cancer, paternal uncle was having diagnosed with prostate cancer, and again he's a married man and wife is a nurse, never smoker. So at the diagnosis of metastatic disease, we can see in the PSMA regarding the extent of the disease. And now again in 2021, he was receiving ADT and abiraterone, then his PSA again started to rise. Followed by that, imaging was done, which showed further progression with new metastatic disease. And again, second pathology review was done. So I think the images that I have, you can just see the amount of the disease burden. It's there in the multiple vertebral bodies, and patient is having rising PSA. So cfDNA was done, and the liquid biopsy here, it showed BRCA1 and BRCA2 mutation with a VAF variant of 21.4. And I think the same was done in the liquid as well. So the biopsy showed in the germline as well, one pathogenic variant of BRCA2 and one another possibly mosaic pathogenic variant of CHEK2 and other genes like EGL1 and FA and CC1. But these both, BRCA2 and CHEK2, were pathogenic, and then patient was started on olaparib. So this was way back in 21, and so the question would have at that point of time, is olaparib the optimal therapy for this patient, or are there any patient characteristics or the clinical factors that would like to, where to incorporate olaparib for this patient? Now let's dive into the discussion for such kind of a case. So why are we so much into targeting the DNA repair in prostate cancer? Because we all know these are the following DNA repair pathways: base excision repair, mismatch repair pathway, NER pathway, and we have homologous directed pathway, which is HRR pathway, or the NHEJ, which is non-homologous. And the genes involved in the base excision pathway, we can just see it. The most important genes that we want to look here is the PARP genes. And the same, if I have to say for HRR pathway, we say it is for the BRCA1 gene along with RAD51 and RAD52. So there are multiple genes, but let us just stick our discussion to the key players. So for the BER, we have PARP1 and PARP2 genes. For HRR pathway, we have BRCA1 and BRCA2. BRCA2 here works in synonymous with FAN-CD gene, and this is what is responsible for the homology-directed repair or the homologous recombinant repair pathway. And how are these two pathway repairs? So at the end of the day, every base pair has to get matched with its counterpart. If at any point there is a deficiency in the recognition, so then these pathway gets activated and they then try to mismatch that gap and ultimately forming the double strand DNA. So for HRR, we have ATM and ATR, BRCA1, BRCA2, and NHEJ, we have ATM, ATR. So we are well versed with this nomenclature. And why is it important? Because it has been found that our alkylators like cisplatin, it acts on the double strand breaks, DNA cross linkage, bulky adducts, and replication lesions. And it does have mismatch repair toxicity. And that is why major DNA pathway, at least one of them, is the HRR pathway. Other drugs also act on the various pathway, but we'll keep our discussion here. So how is this homologous recombinant deficiency can be exploited therapeutically? So just look at this normal cell. Once you have this normal cell and it is getting damages by the external environmental sources or carcinogens, so there happens to be a single strand break, and which is supposed to get repaired either with the fulfillment of the PARP, and then you have a full repair of the DNA, which is the PARP mediated repair, or there can be a double strand break following the single strand break, which has to be done by a HR mediated pathway where BRCA is used for the correction of the break. Now, let's say if the patient is having a BRCA deficiency, and again, this kind of a patient lands up with a single strand break, so the DNA is not repaired then. And that is the concept of synthetic lethality, that we are exploiting the cell which is already having a BRCA or BRCA-like mutation. So what about the subset of prostate cancers which harbor the genomic alteration in these genes? So for the DNA repair genes, we are more focused on this pathway, which is BRCA2, BRCA1, ATM, CDK12. Again, what is the percentage? So for genomic alterations that can occur in the germline or somatic, it can be identified by an NGS. For the germline alteration frequency, if we see the BRCA tend amounts to approximately BRCA2 for 9%, BRCA1 is even less than that, and followed by CHEK2 and ATM. And what about if we go for the synonymous testing for, again, germline and somatic? We have the combination of BRCA1, ATM, and CHEK2 leading to 27% probability in the frequency. Whereas if we go via the single gene mutation, I think here as well, BRCA2 is more prevalent as compared to the BRCA1. So how has been the landmark from 1940 to 2022? So we started with the extramustine, and now we are in late 20, and in fact 2020 we got the approval of olaparib single drug and the PSMA therapy, and the story doesn't stop here. So what is the evidence of PARP in MCRPC? So it all started with the Triton 2 trial, which was rucaparib in the metastatic CRPC with HRR gene alteration. And all these are 12, 13 genes, BRCA1, BRCA2, BARD, BRIP. So these genes were selected, and the patients with metastatic CRPC were selected. And those patients who had already progressed on the prior androgen receptor-directed therapy for prostate cancer, or the patients who have had a taxane-based chemotherapy, were given this rucaparib. Obviously, the patient should have a somatic or a germline GRR alteration. And rucaparib 600 mg BD for 28 days was given. And we can just see in the waterfall graph that the ORR response rate over here with rucaparib was to the tunes of 43%. And out of that, 11% had CR and 32% had PR. So I think the graph is self-explanatory to set the trial Triton 3, where rucaparib versus the physician choice therapy in MCRPC with BRCA1 or BRCA2 or ATM mutations were selected. And again, the important point here was the patient could have had PD on the AR-directed therapy for prostate cancer, and patient should be naive to any PARP inhibitor or chemotherapy for CRPC. Here, the patient was randomized in 2:1 trial. Again, rucaparib was given 600 mg BD, and it was compared to a placebo choice. So if we look at the data from the BRCA subgroup, we can just see that the median PFS in the rucaparib arm, it reached till 11.2 months with a hazard ratio of 0.5. It is quite amazing in the BRCA subgroup. Whereas if the rucaparib was compared to docetaxel in the BRCA subgroup, here also it did show an improvement of 3 to 4 months, again with the hazards of 0.5. And rucaparib versus the second generation androgen receptor therapy, here also rucaparib did show a significant benefit with the hazards of only 0.38. You can just see the amount of months, and it is approximately 8 months benefit. And what about the forest plot here? And we can just identify the most important subgroup here being the patients who are having, BRCA2, because they formed the majority of the patient as compared to the BRCA1, because we know BRCA2 is the most predominant gene getting mutated in the prostate cancer. And if we have to see the type of the control therapy, it did show a betterment in the docetaxel or as well as in the second generation RP. So overall, rucaparib fared better. So then came, the profound trial where olaparib was tested versus the physician choice and in the progressing MCRPC. And obviously the patient need to had an gene alteration in which had its role in the HRR, where it was divided into the two arms, cohort A and cohort B. Cohort A was of only three mutations like BRCA1, BRCA2, and ATM, and rest of the mutations were put in the cohort B. Again, it was divided into 2:1, and we had crossover was allowed upon the progression, the primary endpoint being the PFS. So the PFS showed that the olaparib did better in the mutated arm of cohort A and B as well. This is the overall, and it showed a benefit of 5 months with the hazards of 0.34. Whereas if we look at the overall survival, again, it was a 5-month benefit, a hazards of 0.7. And now we do have the approval of both olaparib and rucaparib in the prostate cancer. And this is the current standard of guideline where we stand today. If the patient is having progression on the novel hormone therapy and no chemo has been given, we can just see we have the preferred regime being olaparib and rucaparib for BRCA mutation. And now we do have the approvals for the combination PARP inhibitors. I would, if the time permit, I will go very briefly into the discussion of niraparib and abiraterone and olaparib and abiraterone in the first line setting. And the patient has
So,
to be...
Dr. Aditya, sir, excellent presentation. Last 2 minutes to complete.
Okay. So I think I will try to wrap it up as soon as possible. So this was Galahad trial, responses with the niraparib in patients with the MCRPC and biallelic DNA damage repair deficient alterations. And again, here it was seen that the niraparib was having an ORR of approximately 34%. Again, the PFS benefit was there and OS benefit was there. If we have to go with the TALA Pro trial, which is for talazoparib in MCRPC, patients having DNA damage repair mutations, we can see that in BRCA1 and BRCA2, the ORR corresponded to approximately 46%, with the median PFS of 11.2 months. So how do tumors with non-BRCA mutation respond to PARP inhibitors? Well, there is a pathway with the name of HRD pathway, and I think we are all well versed. So the Triton True also did an analysis on a subgroup where non-HRD related genes were analyzed, and they did show that some amount of overall response rate was there in ATM in CHECK2. It was not seen in the CDK12. And at the end of 12 months, there was improvement by 16.7% in the ATM arm. And Profound also did show the benefit of approximately 3 months as compared to the air therapy when olaparib was compared. And we are seeing, the more number was in the cohort A arm. And look, if we look at the forest plot over here and the median image-based PFS, we can just see that the BRCA2 patient did drive a good amount of PFS benefit as compared to the control arm with the benefit of 7 to 8 months. And it kept on giving benefit in BRCA2, RAD51, and RAD54. So the take-home messages will be that the PARP inhibitor monotherapy is a standard of care now for BRCA1 and BRCA2 mutated MCRPC after Abira or Enza, or after AR-targeted therapy and a taxane-based therapy. Well, what about the other alterations? Well, we have a label approval of olaparib for PALB2, BRIB, BARD1, RAD51, 54, and we, along with that, ATM, CDK12, and CHECK2 and 1. But we still need better understanding for the gene function in the preclinical models. So I think with this, I would like to end here. I think that due to the paucity of time, I won't be going into the details for the combination trials like NIRA with ADT and OLA with ADT. Thank you. Back to all the organizers.
Thank you. Thank you. Thank you so much, Dr. Aditya, for first finishing in time and such a crisp presentation. Dr. Shams, one or two questions if you have.
Yeah, sure.
Anyone, if you can want to have.
I think the biggest question which still is there in the clinic, I mean, do we use olaparib for patients who harbor mutations other than BRCA1 and BRCA2? Although you showed some data there, but a lot of physicians are not convinced on the usage of olaparib. Your comments, Aditya?
Sir, I think if we have the data which shows an overall response rate in that select subgroup like BRCA2 ATM or PALB2 RAD51 54, I think one can go and jump in with the olaparib because the benefit of the PFS in those select subgroup is more than 6 to 8 months as compared to the control arm. So we need to have the, I think, analysis done first and then, decide regarding the usage of the, drug as compared to the mutation. So the mutation analysis is a must here.
Right. And I think the second question, which the authors have also said, I mean, if you use docetaxel before the use of these PARP inhibitors, the results are even better. So I think that is another point which can be commented upon, that if feasible, docetaxel used uh, before the use of olaparib does give, I believe, additional, hazard ratio advantage.
Yes.
So thank you very
Okay, so thank you. Thank you, sir. Thank you, sir, for this. Now we move to another interesting talk by Dr. Amit Ratan, sir. Good evening, Dr. Amit, sir. Thank you so very much for joining. Sir is the head of the department and consultant medical oncologist at the prestigious Manipal Hospital, Bengaluru. And Dr. Ratan is going to throw light on immune checkpoint inhibitors in the first line metastatic urothelial cancer. So thank you so very much, Dr. Amit. Over to you, sir, for your discussion, please.
Uh, Good evening, everyone. Thank you, Shyam sir. Thank you for this invite. And what I will be talking about is immunotherapy in first-line metastatic urothelial cancer. Are my slides visible? Okay. These slides are changing, right?
Yes, sir.
Okay, thank you. Right. So urothelial
Yes,
cancer.
sir. It is visible.
Okay, thank you. Urothelial cancer was one place where it is one of the unique situations in 2016-17, if you remember, all the 5 immunotherapy drugs which were there, this was the only cancer where all 5 had approval in some form of the other. It could have been a breakthrough approval, it could have been an early approval, but all 5 of them were approved. And this was the only cancer where this was approval was there. And this was in the late line settings. And this was because there was some benefit which was seen. But eventually, a lot of approvals were gone, and then the drugs were withdrawn. And eventually, we had only pembrolizumab now in the late line setting. And that's because of the Keynote 045 data, where you saw in 5-year overall survival, there's a clear improvement, which is beneficial compared to the placebo. And this is probably the whole concept that immunotherapy does help certain group of patients in the late line, but only a small group of patients. So the thought came, why don't we move this upfront and go in first line? And of course, meanwhile, the lung cancer space had changed, and the lung cancer space clearly data was showing chemoimmuno is the way to go forward. And that's why even in the urothelial cancers, the trials were designed saying, let's do first line therapy in the metastatic setting using immuno plus chemo. Now we have the Keynote 361 study, which was looking at first line. Now, these are metastatic urothelial cancers who could be treated with a gem-cis or gem-carbo for patients who were not platinum eligible. And they were compared with pembro plus gem-cis or pembro plus gem-carbo. And there was one arm of pembro alone also in this group. What we saw with these results, they were very disappointing. We saw a numerical improvement in progression-free survival, but it did not reach statistical significance as per design of the trial. And again, a numerical improvement in overall survival. Again, it did not reach statistical significance in the trial. So clearly, adding pembro to chemo was not giving us the gain which we thought we will get the way we had seen the data coming out from lung cancer. Now, simultaneously, we also had the IM Vigor 130 study. And this was looking at as atezo in combination with platinum, very similar trial, looking at platinum with, it could be cis or carbo depending on eligibility with gemcitabine. And again, one arm could be atezo plus platinum gem. And the third arm was atezo monotherapy. Again, a big trial trying to answer the question, could we add immuno to chemo first line setting? And here we saw in the final overall survival, there was no statistical improvement. We went from 13.4 months to about 16 months. Again, not really a great improvement, and it did not meet statistical significance. Now, again, another disappointing result, though there was a lot of analysis trying to look at which subgroups do benefit, and it was seen in this trial that PD-L1 positive patients did show a benefit compared to the PD-L1 negative population. But eventually, the primary endpoint was negative, so this was a negative study. Now, once we learned the concept that if you add immuno to chemo with both these regimens, if you don't have benefit, then there was the other concept which was looked at simultaneously, and that was the Javelin Bladder 100 study. Now, what Javelin Bladder 100 did, it said that you have patients whom you treat with platinum and gem, and once they respond, if you are in a complete response, partial response, or stable disease, so as long as you don't progress, you could offer them maintenance avelumab versus best supportive care. And we know this data has been there for quite some time now. And we've also seen some extended follow-ups. What we saw in the longer follow-up, there is a clear improvement in overall survival, 15 months going to 23.8 months, statistically significant with a hazard of 0.76. There's also an improvement in the progression-free survival, which was statistically significant. So Javelin 100 showed that the maintenance approach clearly was beneficial, and in the subgroups, it was beneficial in all the subgroups, whether you gave GemCis or you gave GemCarbo, whether you had CR, PR, or stable disease, benefit was seen in almost all group of patients. There was a small group where there was no benefit, and that is the upper urothelial tract tumors. That is one place where you did not see the benefit using a Javelin maintenance approach, but for others, everyone else, there was a clear benefit irrespective of PDL1. Now, yes, PDL1 positive had a much higher magnitude of benefit, PDL negative had a lesser magnitude of benefit, but this became the standard of care irrespective of PDL1. So this drew the algorithm. How do we manage metastatic advanced urothelial cancer? So you always ask the same question, are they platinum eligible or are they eligible? And if they are platinum eligible, GemCis was and is the standard treatment you offer. And once you are in any of those stable diseases or responding diseases, you end up giving them Evolumab maintenance. If they are cisplatin ineligible, you give Carbo-Gem followed by Evolumab maintenance. Of course, there was an EV Pembro for this group approved just a year back, but again, I think we will leave that for this place. Now, platinum ineligible patients, one could give them single agent Pembro, or if they were completely ineligible for anything, they would end up with best supportive care. And this was the algorithm which was being followed till the end of 2023. And then post ASCO, suddenly there's been a shuffling and a change in the algorithm for metastatic urothelial cancer. And this change came out because of two studies. The first is the Checkmate 901 study. Now, Checkmate 901 is very similar to our Pembro and Atezo studies, looking at metastatic bladder cancer, first-line setting, but here you are looking at only cisplatin eligible patients. So you had GemCis or GemCis plus Nivo, and they continued Nivo. Now, when you look at this data, there was an improvement in the overall survival, 18.9 months going to 21.7 months with a hazard of 0.78, which did meet statistical significance. Also, there was an improvement in the median PFS, but eventually, if you look at the PFS curves, there's a clear improvement with a hazard of 0.72. The medians may not look very big, but as you follow them with time, you see a clear separation, which is lasting. Now, this study was the first time you had a positive study when you added immuno to chemo, you got a benefit. And this is similar to other studies which we have seen in lung cancer. The benefit which we are seeing is clearly somewhere just remaining there. Now, if you look at all the subgroups, again, irrespective of PDL1, there was a benefit, whether you added Nivo to positive or to negative patients, and all the subgroups showed similar benefits. There was also an improvement in the overall response rate. Now, when you gave chemo alone, you had an overall response rate of 43% with a CR of about 12%. Now, when you gave Nivo plus chemo, your overall response rates went up to 56% with your CR rates going up to almost 22%. So you are increasing the overall rates by around 14%, and you are doubling the CR rate from 12% to 22%. So clear, there is a benefit there. Now, there's a lot of debate about, is this benefit good enough and is this benefit significant enough? Now, again, if you look at our older studies with lung cancer, we would say this benefit is clearly there, and we would say, why would we not use this in clinical practice? But then when you look at the curves, there are a lot of people who say, look at that PFS curve. You see the separation, which starts off after 6 months, and that is the time when you are actually, you finish the chemo and then you continue the immuno. So you keep thinking, is this similar to the Javelin study? Is the benefit the same, or is the benefit, would it have been the same benefit if you had given it later? Now, there's no answer to this, but definitely there is an improvement in ORR, there's improvement in PFS, there's improvement in CR, there's improvement in overall survival. So clearly this is a positive study, and this is approved for use as first-line setting. Nivo plus chemo can be done. Unfortunately for them, in ESMO 2023, this meeting, there was a simultaneous next presentation, and EV302 stole the show completely. This was again a first-line study where you're using the chemo was GemCis or GemCarbo, and it was being compared with EV plus Pembro. And we know We know all the data from EV and late line settings had clearly shown a benefit as a single agent drug. We also had seen data with combination of EV plus Pembro in the cisplatin ineligible segment, and it again showed us very good responses. And this was looking at first line settings for patient who is cisplatin eligible or ineligible. And this was looking at EV plus Pembro. Now, if you look at these responses and these results, clearly they are dramatically different. You saw a PFS going up from 6.3 months to 12.5 months. You are doubling the progression-free survival, and your hazard was 0.45. And if you look at overall survival, 16.1 months going to 31.5 months. These are figures you have never seen in bladder cancer in the metastatic setting. So clear improvement with very good hazards of 0.45 for PFS, 0.47 for overall survival. And that's why this presentation clearly overshadowed the Nivo presentation. Unfortunately, if they were in two different meetings, then the Nivo would have been really talked about and appreciated, saying that it was the first time Nivo has shown benefit where Atezo and Pembro did not. But with the EV302 data, the data was so marked benefits that everyone's just talking about this. And clearly, there's no reason why they should not. Now, look at the overall response rates. Again, you got 44.4%. That's almost the same you got in the Nivo trial with a CR of 12.5%. Here, the response rate went up to 67.7% and your CR rate went up to 29%. So we are talking of almost 30% patients getting into complete response in the metastatic urothelial space. And this is something we have never seen before. So clearly, this is a very effective combination in the first-line space. They did analysis looking at, did it matter if the PD-L1 was high? Greater than 10% is what they showed. Yes, it did not matter. And they also showed low CPS less than 10. Unfortunately, I don't think we have seen the data. I couldn't find out the data saying that what if PD-L1 was 0, because less than 1 could be anything, less than 10 could be anything. And we don't have those data sets yet, I think, where what happens to patients with PD-L1 0 or low, very low. But eventually, I think the benefit is going to be the same. Looking at these curves, clearly the benefit is probably going to be the same. There is going to be a unique toxicity and a unique learning experience when we start using EV Pembro in practice. What we saw in this trial, clearly the chemo side effects were as we expected. Anemia, neutropenia, thrombocytopenia when you end up giving the chemo, which was very low when you did EV Pembro. What you did see more, you saw more peripheral sensory neuropathy, which you would expect because of the EV. You saw more pruritus. You saw some rashes, which were much more. And I think these are going to be the unique toxicities which we are going to learn about when we start using EV Pembro. There were also some ocular toxicities which we'll have to learn about when we start using ADCs in first-line practice. And sometimes also sugar management may be important when you're talking about EV usage in clinical practice. But I think this is not going to be a deterrent at all. It's actually going to be better because if you see in comparison to chemo, the toxicities are so much lesser with all those anemias, neutropenias, thrombocytopenia, which we face with when we do GemCis into clinical practice. So what happens with this? You have changed the algorithm and it's dramatically changed from the last year end. And you've seen all the guidelines now reshuffled. If you have a metastatic urothelial cancer and if they are platinum eligible, you could do the old approach. You do GemCis with Evolumab maintenance, perfectly fine. Whoever believes and says, I want to do the Evolumab approach, I want to give it only to responders who do well and then give them Evolumab. I don't want to offer immuno to everyone. Or some people could say, I would do the Nivo GemCis approach. If my patient is cis eligible, GemCis plus Nivo, I would like to put the immuno directly up front. I don't want to lose out those few patients so that I may not end up offering them immunotherapy. So I would give them directly GemCis Nivo. Now, I think the third approach, which has come in EV Pembro, is clearly superior than both of them in terms of ORRs, in terms of CRs, in terms of PFS, in terms of overall survival. And I think that approach is clearly there and it is clearly approved for use. As EV gets available in the country, once EV is there in India, I think this usage will jump up hugely because those responses cannot be mimicked by anything else. Yes, we do hear a lot of debates. People say, what would you do if you progressed on EV Pembro? Then what would you use? It would end up with being chemo. I'm sure they are chemo unexposed. We would probably end up giving some form of gem platins. Other question asked is toxicity and long-term, how are we going to adapt to giving EV so long? I think in India, we are all going to learn to use it better. We'll probably give for some time and then we would withdraw the EV. We wouldn't do indefinite EV, just like what we do with immunotherapy. It's not that we are really doing, every patient doesn't get the full-fledged immuno once they have responded. So these are things we will adapt to practice. But I think that EV Pembro is right there, dominating that space, and is going to become the major player in this kind of setting. Now, if the cisplatin ineligible, again, we talk of carbogem, Evelvam maintenance, but we again here the EV Pembro data is really very good, and that's what we will lean towards. So we have really reshuffled the space in just a few months now. In last 6 months, the whole space is reshuffled, and I think we will be adapting to better using of these drugs for our patients in urothelial cancer. But the good thing is we are improving their survivals, we are improving their quality of life, and that's the wonderful thing. Thank you very much.
So thank you very much, Dr. Amit. It was always wonderful to listen to your talk and your views. So, I mean, did I hear the issue of PDL1 testing in Nevo setting? I mean, is that required, or are the results different for PDL1 positive and PDL1 negative?
No, sir. For the Nevo setting, there is no problem. Both PDL1 positive and negative showed the same benefit in terms of hazards.
So, in the current scenario, that would become the first line therapy if somebody can afford?
For our setting in India, yes, sir. I think Gem Cis Nevo would be our first line, but only for those patients who are cisplatin eligible. Because what if they are not cisplatin? Whether we can do Gem, Carbo, Nevo, I don't think so, according to the clinical trial.
Right. So, and EV is still, people are looking at I mean, we don't have it at the moment in our context.
Yes, sir. I think this year we are hearing it may come in the end of the year. If that happens, then probably the space will change.
Yeah, I think amazing results with this combination. I mean, unprecedented, outcomes as we are seeing. So, any other question from the audience to Dr. Amit? I think he's open for discussion. Okay, thank you. If not, we move ahead. Tarun?
Yeah, thank you. Thank you so much, Dr. Ahmed, sir. And we have another next very important topic, and it's a pleasure to welcome and invite Dr. Dipanjan Panda, sir. Good evening, Dr. Dipanjan, sir. He's a senior consultant medical oncologist at the prestigious Indraprastha Apollo Hospital, New Delhi. And he's going to talk on maintain to extend the right treatment approach in metastatic urothelial cancer. Good evening once again. Welcome, sir. Over to you for your presentation.
Thank you. Am I audible?
Yes, sir. If you can share your slide.
Yeah. I think my slide is visible.
Yes, sir. Your slides are
These were the two
visible.
most
You're audible.
am I audible or my slide is visible? Whether I will be understandable, that I cannot promise. Anyway, I thank Dr. Shyam Agarwal for kindly allowing me this talk. So the next 15 minutes, I will try to navigate through the current treatment approaches for extending survival in metastatic urothelial cancer. So if we look at the just a moment, I need to, yeah. If we look at treatment approaches to maximize survival, both cisplatin eligible and cisplatin ineligible or carboplatin eligible patient, we can roughly put them into 3 groups. I call them wait and watch, where you can use the first-line chemotherapy, got a PFS, wait, disease progression, you initiated second-line therapy. Or there is a switch maintenance group where you use chemotherapy for a fixed duration, that chemotherapy
Tarun?
Yeah, hello. Dr. Dipanjan, sir, we lost you.
So Dr. Deepanjan sir is not there.
Sir, maybe the network
Let's
issue.
wait. हाँ,
Wait
एक
for
बार
1
phone
or
कर
2
लीजिए.
minutes. Na?
Yeah.
Hello. Sorry.
Yes, sir. Your voice is audible, sir.
Did the connection get lost in between for a split second?
Sir, yes, from your side is technical issues.
Oh, now is okay, right?
Yes, sir.
Okay. So as I said, there have been three groups called wait and watch. Switch.
Deepanjan sir, kindly share your slide, please.
Oh, sorry. I think there was in between. There was just a minute. Just a minute. Please give me a sec. Is the slide visible now?
Yes, sir. Make it full screen, please.
I will. Just give me a. Oh.
Please click on the bottom. So zoom in and the left icon. Yeah.
Now is it okay?
Yes, sir.
Yes.
Move on.
Sorry for these technical issues. I think there was for a point second the internet connection went on. Anyway, so there was, as I said, there was a wait and watch. There is switch maintenance and there is a continuation of maintenance where you start with the first line chemo with IO, then continue IO maintenance and initiate the second line therapy on disease progression. If you look at the overall survival with chemotherapy followed by IO, then we have the data from Keynote 045, where we have a first-line chemotherapy with a PFS of PFS and a median overall survival of 5 to 6 months, and followed by a second-line pembrolizumab, which gives a rough median overall survival of about 10 months. And it shows that this Keynote 045 shows that pembrolizumab prolonged median overall survival in all the patient subgroup analyzed when you compare along with the chemotherapy maintenance, namely the taxane and veniflurin. Now, coming from for the switch maintenance, there has to be some rationale for giving switch maintenance, that is first-line chemotherapy for fixed duration and a switch to IO maintenance. So it has been postulated that decrease the tumor burden to achieve disease control and increasing the immunogenicity of the tumor microenvironment by chemotherapy can lead to a better efficacy of immunotherapy in patients who have a reduced tumor burden and high mutational burden like urothelial cancer. So it has been postulated that the cytotoxic and immunogenic effects of platinum-based chemotherapy provides the opportunity to enhance clinical efficacy with ICI maintenance therapy. But as they say, the proof of pie is in eating. So I'm not being able to view that. Yeah. So to prove that this particular phase 3 randomized open-label study, that is Javelin Bladder 100, that showed that this postulate is right. So what did Javelin Bladder 100 did show? It shows that an induction chemotherapy in a case of unresectable, locally advanced or metastatic urothelial carcinoma with a measurable stage 4 disease who received 4 to 6 cycles of gemcitabine with platinum, preferably cisplatin, and for cisplatin ineligible patients, carboplatin in gemcitabine. Then a treatment-free interval of 4 to 10 weeks, where a radiological assessment of response was done, and patient with CR, PR, or stable disease was randomized into maintenance avelumab 10 milligram per kg every 2 weekly, plus best supportive care versus best supportive care alone until progressive disease or unacceptable toxicity or withdrawal. The primary endpoint was overall survival. Secondary endpoint was PFS, overall response, time to response, response duration, disease control, safety, tolerability, and patient-related outcome. All endpoints were measured post-randomization. Now, The primary endpoint, needless to say, it was achieved. The median overall survival for the start of chemotherapy. It shows that avelumab plus best supportive care has a median overall survival of 29.7 months compared to best supportive care, which is 20.5, which means there is a 9.2 months improvement in median overall survival and 23% risk in the reduction. The median overall progression-free survival was also better in avelumab group, 5.5 months versus 2.1 months. The stratified H hazard ratio for disease progression was 0.54. So there is a 46% improvement in progression-free survival. Not only that, overall survival benefit was observed irrespective of the number of first-line chemotherapy, 4 cycles versus 6 cycles, although 6 cycles were numerically superior, but both of them, the avelumab maintenance did show improvement in survival, whether you receive 4 cycles chemotherapy followed by maintenance versus 6 cycles of chemotherapy followed by maintenance. Not only that, irrespective of whether you have received cisplatin or carboplatin, the avelumab maintenance shows overall survival benefit compared to best supportive care. Although I must say that cisplatin group was numerically superior. Needless to say, and also that overall survival and PFS benefit with avelumab was seen irrespective of the best response to chemotherapy, whether it was CR, PR, or SD. So the hazard ratio was 0.72, 0.70, and 0.84. But it showed better response on all the subset. Another important aspect of this particular trial, JB100, is that 21% of the patient was from Asian subgroup. So this Asian subgroup shows a 28.7 versus 18.2 months. And the PFS was 5.6 versus 1.9 months, which was almost similar to the whole group. That shows, and this we have also patient from India also. So 61% Asian patient was alive after 2 years and more than 10 months of median overall survival benefit over non-avelumab maintenance. And the PFS was roughly 3 times more compared to non-avelumab maintenance. Safety profile, if you look at it, that the treatment-related adverse event of any grade occurring in more than 5% or grade 3 event occurring more than 2%, the safety analyst said, pruritus, hypothyroidism, diarrhea, infusion-related reactions were more common. Grade 3 reactions, the commonest reactions has been increased amylase level and increased lipase level. And now we always nowadays question that in trial is more like, in like a culture plate where settings are very, very controlled. So what is the real world data? Now there has been at least 2 real world trial. One is Evidence and one is Ready, which did show similar PFS and a similar OS compared to JB100. In Evidence, the median PFS was 5.7 months, where the JB100 at 5.5. In Ready trial, in fact, it was 8.1 months. And the median overall survival in Evidence was 26.5, and in Ready it did not reach. So without going into this cross-trial comparison, we can say they demonstrated that there is a consistency across real-world study and the Javelin Bladder 100 clinical trial. This much I think we can safely say. So what is Evidence? It's an ongoing multi-center ambispective, that is retrospective cum prospective non-intervention study of locally advanced or metastatic urothelial cancer with Bavencio maintenance. Started in 13 July 2021, up to 4 years of follow-up, primary endpoint being overall survival from the start of Bavencio's treatment. And there are secondary endpoints like overall survival, start of first-line chemo, PFS, duration of response, and safety. There is a 40.8 months overall survival in this real-world study, that if you're taking platinum-based chemo, then got a CR, PR, or SD, and got an avelumab maintenance, and add a second-line N42 vedotin. We'll come to that later. Now, there has been some approach to maximize the overall survival with IO upfront in combination with chemotherapy. with a continuation of maintenance. So we have InVigor 130, where they use atezo-gemcis with gemcis or carbo. Unfortunately, there was no significant outcome in difference in OS. It was a negative trial, and the hazard ratio was 0.84. Median overall survival gain was 2.7 months. Keynote 361, where pembrolizumab was added with gemcis or gemcarbo versus gemcis or carbo. Also, it did not meet the OS or PFS primary endpoint. It was a negative trial with a gain of about 2.7 months. The only trial which was positive in this was Checkmate 901, which we'll briefly discuss. It was Nivo plus gemcis versus gemcis. The PFS and OS endpoint was only in cisplatin eligible subgroup. It had a 2.8 month survival with a 0.78 hazard ratio. The study design of Checkmate 901 had Nivo 360 with gemcitabine 1000 milligram meter square day 1, day 8 versus cisplatin 70 milligram per meter square day 1 every 3 weekly up to 6 cycle versus gemcis in the same dose, followed by Nivo 484 weekly maintenance. Primary endpoint was OS PFS by blinded independent review. Secondary endpoint OS PFS by PDL1 more than 1% and health-related quality. So there is 7-point median PFS of Nivo plus GC was 7.9 months and GC was 7.6. So this is actually a 9 days of PFS benefit. Now it may be statistically significant, but whether it's clinically meaningful or not, I'm not very sure. Coming to the primary endpoint of overall survival, there is a hazard ratio of, I think, 21.7 versus 18.9, that is 2.8 months, I've already mentioned. If you consider this JV100 and nivolumab trial, I think the first line eligible population was 8 out of 10 in Bevantio, 5 versus 5 out of 10. Both with any platinum eligible patient was eligible, patients was eligible in Bevantio, but only cisplatin eligible patient was taken in nivolumab trial. The median follow-up of Bevantio was slightly higher, and it also included Indian patients. And a comparator arm was best supportive care followed by immunotherapy by 74% of the patient, where in the comparator arm of Nivo trial, only 11% of patients actually got avelumab maintenance. So this is a numerical trial. So at least I think, at least numerically, it is the Bevantio trial, the Javelin 1000 seems to be more promising to me than the Nivo plus GC. Now, approach to maximize the overall survival of IO upfront, along with other IO or TKI or antibody drug conjugate. So Danube trial, which used durvalumab with Trime, was a negative trial. LEAP 011, which is a Pembro plus Lenva, also a negative trial. But the real important trial, which Dr. Amit has really spoken, and we are all, is that enfortumab vedotin with Pembro, which made the PFS and OS endpoint, and it was a positive trial, and it really has shown that the way things are. So let us discuss this EV302 keynote A39 with a slightly more detail. So previously untreated locally advanced metastatic urinary cell cancer, eligible for platinum, enfortumab, PDL1 inhibitor, NAVE, and GFR should be more than 30 ml per minute. And of course, the ECOG should be less than 2. EV plus Pembro, no maximum treatment cycle for EV, maximum 35% cycle for Pembro versus chemo, cis or carbo plus gem, maximum 6 cycles.
Dr. Dipanjan, sir,
I'll just take
extremely sorry to interrupt you. Just last 2 minutes to conclude with your.
Yep, sure. I'm sorry. I think there was 1-2 minutes. So it shows an overall survival of 78.2% versus 61% in 12 months and at 69.5 versus 44.7%. And it was a positive trial, but it did not compare versus the current standard of care, that is platinum chemo versus Avelo. So we did not have a direct head-to-head trial of Javelin 100 versus EV trial. So I think we have only. And a second point I wanted to include that EV has a significant toxicity there, including peripheral neuropathy. We also have lost recently one patient of coagulation issues. And also there are other issues like hyperglycemia, dry eye, motor events. So it's not very easy drug to administer. At least that's what my personal experience from a couple of patients are. So if you look at the total first-line avelumab maintenance followed by second-line EV, I can show you that ultimately, if you Avenance and JB100 protocol has shown that if you have used first-line avelumab with CT followed by antibody drug conjugate, you can have a higher overall survival. So in summary, I would like to say that treatment landscape of metastatic urothelial carcinoma is evolving. Platinum-containing chemo has a high initial response rate, but response are not long-lasting. Maintenance avelumab have significantly increases the overall survival to a tune of 30 months. The OS benefit of avelumab first-line maintenance occur irrespective of the first-line chemo, duration of chemo, response to chemo, and treatment-free interval. Nivo-GC is a positive study, no doubt, but I believe the result is a minor increment in PFS and OS. Pembro EV definitely looks good, and I'm sure this is going to be one of the new standard of care, but only red flag is you need to be cautious with the toxicity profile, and you need to choose your patient. And finally, I think sequencing of available options, that is first-line avelumab followed by enfortumab vedotin, might result in a better overall survival. With that, I thank, and I'm sorry because of that technical glitch, I overshoot my time. Thank you.
Thank you so very much. I think you're bang on time, and thanks for this wonderful presentation. I'll leave to the audience for some couple of questions. So if Dr. Sham sir wish to ask, and anyone, Dr. Dipanjan sir, insight is already there. So please, any questions? Sham sir or anyone?
Yeah. So Dipanjan, I think
Sir.
I mean, you did point out that the battle is between cisgem nivo versus the chemo followed by avelumab.
Sir.
And so you did tell us that the differences with cisgem nivo are not too much in terms of PFS, but only towards the tail, the start.
Exactly.
So what is the current treatment which you offer?
Sir, I preferably, if the patient has a GFR of 60 or more, I offer them 4 cycles of Gemcis. And if they have a CR, PR or stable disease, I put them on avelumab maintenance. If the patient has a GFR less than 60 but more than 40, I put them on full dose carboplatin, AUC4. If they have a GFR between 20 to 40, I give them 50% of the calculated carboplatin dose with gemcitabine. And any patient who is 60 or more, I always do a DTPA renogram to find the exact GFR and do not calculate them with creatinine. In fact, we have one of our students did a study on patients more than 65 years, and we found there is a discrepancy because you know that original Cochrane formula had nomogram, which was not basically ready for the elderly patient. So that I would suggest that is. Otherwise, I'm quite comfortable with avelumab maintenance, except the cost, which I believe is a little higher. In fact, with the Nivo support program, I think the cost thing Mark has to decide. Otherwise, especially in the long survival patient, the cost difference is going to be high. That's the one problem. But that problem is there with enfortumab with Pembro also.
Right. So, yeah, I think the cost will gradually, I think the avelumab people will also come in with some kind of PAP.
Oh, one real advantage of avelumab, sir, it is both gem and carbo. Nivo, that trial has a problem. They did not take carboplatin patients. Otherwise, there are at least 30 to 40% of my urothelial cancer patient may be borderline GFR, where you have to be really careful of using cisplatin. So that is one point I think goes slightly against Nivo-GC. So I'm not saying that's the one, but when I have to take a point, I think I usually go by what I have seen, trusted. I'm using this combination, and I think I'm okay.
Great. So I think these are absolutely, nice takeaway take-home points that we must look at the DTPA, must look at the GFR, and take a call on the usage of the platinum drugs, and of course that decides whether you. I think I fully agree with you that the Nivo data is, although there is an FDA approval, but then not very sort of promising that way in the early part at least. So I think avelumab stays with us at this point in time for bladder. in the switch maintenance, and we do have the results which are promising. And I think we all have patients who are taking avelumab beyond 8 to 12 months in the maintenance. Dipanjan, you have a patient?
Yes, sir. I have two patients, and both of them has crossed. One of them, in fact, crossed 2 years. I actually put it in the group of our AIMS alumni group whether I should stop it, but there was no taker. And patient is a retired executive director of one of the top PSU, so he continues. So I told him that, sir, I will talk to our colleague, and I cited the Pembro one, but I found among my peer group no taker of stopping the treatment since the patient is in control and patient is tolerating. So I have decided to continue. But I think that also, sir, we have to, maybe we need to do some trial to see whether continuation of immunotherapy for a beyond some, only, I think only Pembro has given a specific that after 35 cycle is stop. I think in no other company is willing for whatever reason. But I think there has to be an investigator-initiated trial to see if the disease is under control and you have got an immune memory. That is after beyond 2 years, whether you need to continue immunotherapy. I think that has to be some sort of trial which we have to come together and see.
I fully agree, because I think we all have patients who were forced to stop the IO drug due to some toxicity beyond few months, and they're living absolutely fine after taking the drug for 8 to 10 months. And I mean, we all have patients who are going beyond 2-3 years without any treatment.
Absolutely, sir. I think memory T cell has some, they remember, it remembers. So whether we need to actually pursue, that will be difficult for companies to,
Correct, right. I mean, it's not an easy study to perform. Yeah. Great.
So extremely sorry to come in between. Sorry, Dr. Sham, we are running behind schedule. So with your permission, we have a pleasure to welcome and invite Dr. Aditya Murli. Sir, good evening to you. And Dr. Aditya is the Senior Consultant Medical Oncology at Apollo Hospital, Bangalore, the Garden City. Thank you so much, Dr. Aditya, for joining us. And he's going to throw some light on first-line treatment for advanced clear cell renal cell carcinoma. So over to you, sir, for your presentation.
Thank you, Dr. Sham, sir, for such the kind invite, and thanks, Sarunji, for involving me. I hope I'm audible and my screen is visible.
Perfect.
Yes, sir. Your
Perfect.
voice is
Perfect.
audible and your PPT is visible.
Fantastic. So 10 years back, this used to be the most boring, bland topic. We had one drug to treat, which was more often unaffordable, and it was basically an MCQ tick mark question. RCC gives sunitinib, RCC gives sunitinib. Unfortunately or fortunately for our patients, last 10 years have been a period of phenomenal advancements in this field. We know that clear cell RCC is the most common subtype. Roughly about 70 to 80% of RCCs are the clear cell subtype. There are other subtypes like papillary and chromophobe type, and we will not be talking about those too much today. But essentially, the gist of my talk is to look at what all first line options that we have, which can control the patient, the cancer growth, and improve the patient outcomes that we have. So whenever we talk about RCC or metastatic clear cell RCC, the most important criteria for us to decide treatment is the IMDC risk criteria. So this was published in 2009, work done by Heng et al. From MSKCC. And even prior to this, we always knew that not all RCCs behave the same way. We all have had one of RCC who has gone on for 7, 8, 10 years on sunitinib. But I think the key for RCC outcome lies in this IMDC criteria. The important components of this criteria are the performance status, the time from the initial diagnosis to targeted treatment, hemoglobin, calcium, platelet count, and neutrophil count. I think all of these, we have to make a habit of noting it down in the patient's file. So a diagnosis of RCC is never complete if we don't add the historical subtype and the IMDC risk score. And I'll tell you why it's important. If a patient has got 3 or more risk factors and patient falls into the poor risk category, the 2-year survival is just 7%. You can contrast that with a favorable or none of the risk factors, zero risk factors. A favorable metastatic RCC has got a 2-year survival of 75%. So there is such a huge difference. Okay, even if we look at, let's say, intermediate risk, which is just 1 or 2 risk factors, even 50% of the patients are alive at 2 years. But the difference between intermediate and poor risk is phenomenal. And if we are able to identify this subset of patients, then we can definitely go above and beyond and try and see how best to improve their lives and their outcomes. So here are the key few studies for metastatic RCC. I'll be talking about the Checkmate 214, which is Nivo-EP versus sunitinib. The Checkmate 426, so the Keynote 426, which is axitinib pembro versus sunitinib. The Checkmate 9R, which is Nivo-Cabo versus sunitinib. The Clear trial, which is Lenva pembro versus sunitinib, and the Cosmic 313, which is Nivo-EP Cabo versus Nivo-EP. So I think the theme of this slide here is that the comparator arm for all of these is sunitinib, which was still 10 years ago the standard of care. So it's not like the comparator arm is a lightweight. It's not like the current Indian election. So it's a well-matched comparator arm, and across the board, all of these trials showed a significant improvement. Let us talk about the first trial, which is the combination of IO. Checkmate 214 was a combination of Nivo-EP versus sunitinib in the comparator arm. In the intention to treat analysis, all risk criteria were included, including the poor risk, the intermediate risk, and the good risk as well. When we looked at the all risk criteria, the 5-year survival was nearly 50% with Nivo-EP. Mind you, this is one trial which has got the longest median follow-up possible. When we look at the median PFS, again, the 5-year PFS was 30%. A third of the patients who received Nivo-EP had a progression-free survival at nearly 5 years. But if you look at the ITT, the hazard here is just 0.86, which is not statistically significant. And that is probably because we are trying to include all 3 risk criteria in this. But when we look at the actual risk grouping, we select out the favorable risk and we look at only the intermediate poor risk. Here is where the real advantage of the Nivo-EP combination comes through. The Nivo-EP combination has a hazard of 0.68 over sunitinib, and the 5-year overall survival. Let us contrast this with the very first slide which I showed. The 5-year overall survival for even intermediate poor risk metastatic RCC is nearly 40% if the patient went on the Nivo-EP protocol. So that goes to show the phenomenal improvement in the outcomes with the IO-IO combination. Every other IO has been tried with the TKI combination. And why is that? Traditionally, VEGF TKIs were the standard of care for RCC, and there is preclinical data to show that there is a complementary mechanism of action when we combine immuno-oncology molecules with VEGF TKIs. The first trial is the Keynote 426 trial. This looked at first-line pembro-axi versus sunitinib. If we look at the PFS data that we have, mind you, at 2 years, the pembrolizumab was stopped in this trial. Per protocol, at 2 years, pembrolizumab was stopped. Patient just continue the axitinib. And even then, at the 3-year mark, 30% of the patients were progression-free if they received pembro-axitinib. When we look at the overall survival, the 3-year overall survival was nearly 63% in the pembro-axitinib arm. This is updated data from ASCO 2023, but what is a little bit more revealing is if we try and divide it in the intermediate poor risk and the favorable risk. Again, in the favorable risk, there was no benefit of combining pembro-axi versus sunitinib, and there was no statistical difference between both the arms. Having said that, there was a stark difference in the intermediate poor risk criteria metastatic RCC with a hazard of nearly 0.64 for the overall survival. The median PFS was 13.8 months with pembro-axitinib and only about 8.2 months with sunitinib in the intermediate poor risk arm. The next combination of IO-TKI is the Checkmate 9ER. this combined nivolumab with cabozantinib. Mind you, the dose of cabozantinib in this trial and what we use in our own setting is very different. But having said that, the hazards for PFS were nearly 0.58. Again, why I want to stress here and what is so impressive is that we can see these hazards when we are combining a targeted therapy with a chemo regimen. But when you are trying to compare one targeted regimen with another IOTK regimen and still having hazards of 0.5, 0.6, they are phenomenal. That really goes to show that this is a game-changing new line of treatment for patients with metastatic RCC. When we look at the overall survival, the 3-year overall survival for Nivo-Cabo was about 58.7%. Then came a more popular, a very popular trial called the CLEAR trial, and for no particular reason, this is a personal favorite for me. The lenvatinib pembrolizumab was the experimental arm in the CLEAR trial, and the comparator arm was everolimus or sunitinib. And if you see over here, we can look at so nicely the trail of the curve over here. And if we look at the hazard for lenvatinib pembro versus sunitinib, the hazard was 0.39. If we look at the 3-year PFS for lenvatinib pembrolizumab, that was nearly 40%. So the median PFS for lenvatinib pembrolizumab was 2 years in advanced metastatic clear cell RCC. When we looked at the probability of the OS, the median overall survival with the lenvatinib pembrolizumab had not yet reached at the time of this particular presentation. But the next trial that we will be talking about is the Cosmic 313 trial. In this trial, the investigators felt, can we go one step further? Can we add the IO and the TKI? How important is a triple drug regimen? And more importantly, can we do anything to improve our outcomes in the poor risk metastatic RCCs? Unfortunately, the triple drug regimen failed in the poor risk RCCs. As you can see from the Kaplan-Meier curves over here, there was no difference in the both the arms. There was no statistical significance here. And probably a lot of it has got to do with the toxicity of this. So if we know cabozantinib in itself is a fairly toxic regimen. And even the EP-Nivo, if we use EP at 1 and Nivo at 3, even some patients too still get into trouble with that. But the Cabo EP Nivo arm had a 50% dropout rate and treatment discontinuation due to adverse events. And this almost never bodes well for our patient. So for now, the best we can do in a poor risk, it's still going to be a IO-IO combination, but trying to do the triple drug regimen in a poor risk is still not become the standard of care. So this one slide sort of encapsulates all the first line IO trials that we have for metastatic RCC. Cross trial comparisons are never a great idea, but just to give one single snapshot, in terms of the median follow-up that we have, the longest data that we have is for the EP-Nivo combination, and this has stood the test of time. The median overall survival in the EP-Nivo intention to treat was 55.7 months. If we look at the median PFS, the best that we have is lenvatinib pembrolizumab, which is nearly 2 years. If we look at the overall response rates and maybe the so this one slide I like to talk about in whenever I talk about RCC, that's because there are about 18% of the patients in or 1/5 of the patients of metastatic RCC who absolutely don't respond to Nivo EP at all. So the PD rates in if a patient went on the Nivo EP combination is about 18%. So we still don't know who will not respond. Hopefully time will give that answer. But until that time, these are the combinations that we have with us. So all of this does bring us to the unanswered questions. In a high risk, in a intermediate, in a high risk at least, with the data that we have with some cross trial comparisons, maybe IO is probably better. But in the intermediate risk population, we still don't know IO or IO-TKI. Everybody has their personal favorite and their data. I tend to pick lenvatinib pembrolizumab, but that's purely because of the PFS of about 2 years. If there is brain metastasis, then maybe Nivo EP is a good first line choice. If there is a lot of disease bulk, then IOTKI probably is the way to go. Each patient of RCC will have their own set of comorbidities, and side effect profiles of all of these combinations important, especially when we are looking at patients who've got high blood pressure. Maybe in them, some of the TKIs will be difficult and IO might be a good idea. Has cytoreductive nephrectomy completely been binned? Probably not. Even now in clinic, in a low volume metastatic disease, we routinely do recommend cytoreductive nephrectomies that cannot be binned as of yet. Some of the interesting trials that we have. So finally, we have got the 3G or the 5G version of the trials for metastatic RCCs. In the PROBE trial, we are trying to compare IO-TKI with or without IO-TKI or EP-Nivo with or without cytoreductive nephrectomy. I think this is going to be one really, really impressive trial, and hopefully this will give us some answer. There is a Samurai trial which is trying to look at SBRT in the intermediate poor risk RCCs, and maybe this can also throw up something interesting. So to conclude my talk, I think first-line treatments for advanced clear cell RCCs do play a crucial role in controlling the disease and improving outcomes. If a patient has IMDC, risk scoring is everything while trying to decide treatment options. If a patient has favorable risk IMDC risk scoring, it's not unreasonable just to give, if it's especially a low disease bulk, good biology disease has relapsed after 5-6 years, maybe sunitinib alone or pazopanib alone is a reasonable choice. Pembroaxi has shown reasonable data in favorable risk also, but if a patient has intermediate poor risk, Nivo EP or Pembroaxi is probably the way to go. Thank you all for a patient listening. I'm happy to take any questions.
Thank you, sir. Thank you for the excellent presentation. Any questions, sir? 1 minute is there to take up the questions.
So thank you very much, Aditya, for this fascinating talk. And we are all sort of spoiled for choices today. So what is your experience with lenvatinib in terms of the side effects of the TKI?
So learning how to use lenvatinib did take some time, but I do start with 8 milligrams, and with 8 milligrams, patients do tend to tolerate. Fatigue maybe a little bit, but apart from that, not too much of an issue, especially having used Nivo EP also, and the first few cycles of EP is a little difficult. Pembroaxi, maybe Pembrolenva might be a reasonable choice, but if we say the probability of side effects, if it's a very elderly patient, let's say if it's a 75, 80-year-old patient, and a patient has got hypertension and any of those, IO is probably a easier to tolerate drug than lenvatinib pembrolizumab, sir.
Right. So does the disease bulk, affect your treatment choice? If somebody has a lot of visceral disease in lungs.
So absolutely, sir. I think the three biggest things are the risk scoring, the bulk of the disease, and the site of the Mets. If it's an intermediate poor risk, and if it's a bulky disease, lot of visceral disease, IOTK is probably preferable, given that we want to try and get a quick response. If it is brain metastasis, then IO probably has got some more data there.
Great. So I think learning points there for all of us. So thanks, Aditya, for your time and for the presentation. Thank you very much.
Thank you, sir. Thank you, Aditya, sir. So we move to session 2 on hepatobiliary cancer. And for that, I would like to invite Dr. Sumit Goyal, who is Senior Consultant, Department of Medical Oncology at Rajiv Gandhi Cancer Institute. And sir is going to talk on emerging adjuvant therapies for high-risk HCC. Over to you, sir.
Good evening, everyone. Thank you, Shyam sir, for giving us this opportunity today to interact. Hope I am audible and my slides are visible. So
Yes,
shall
sir.
I proceed? Yeah, okay. So my topic is very novel one, emerging adjuvant therapies for high-risk HCC. So HCC, we know adjuvant strategies, a very difficult choice. So basically, a disclaimer, slides and content are taken from various sources and the copyright belongs to respective authors and presenters. So if we talk about adjuvant therapies, like my previous speaker said for RCC, we are still stuck with sorafenib for a long time. We'll see they were very like dearth of therapies which were available. So we know it is an aggressive and primary liver cancer which is there, and HCC high risk HCC refers to basically advanced stage or recurrent disease. It carries a poor prognosis. And for such aggressive disease, unfortunately, we do not have much adjuvant therapies. And maybe these adjuvant therapies in coming days may play a crucial role for improving the outcomes of patients who have high risk HCC. So we know most of the HCC occurs in the setting of underlying cirrhosis. So there are very causes, but we need to remember there are causes like hepatitis B, which can progress directly without underlying cirrhosis also. So does it carry some role? Probably there are studies, we'll look into it. So we look at the epidemiology again, the estimated risk is likely to increase everywhere, be it Asia, be it Europe, be it US. So by 2040 and by 2040, it is likely to become the third most common cause of cancer-related death in US. So again, there is an other problem which is happening, that is NASH. So from viral etiology to NASH, the incidence is again increasing. It may have some bearing on the treatment, both in the adjuvant or in the metastatic advanced setting also. So if we look at the standard of care these days for early stage HCC, the surgical resection and liver transplant are the main curative treatments for HCC, and high risk HCC patients often experience disease recurrence. So we need adjuvant therapies to reduce the risk of recurrence and to improve the survival rates for these patients. So if we look at the NCCN guidelines, so in NCCN guidelines, basically for early stage, it is the resection, transplant, local therapies, ablation, microwave ablation, radiation, or eligible patient transplant, followed directly by surveillance. But there is a footnote there. If we look closely at that footnote, it says adjuvant therapy with atezolizumab may be considered in patient at high risk for recurrence. So high risk here is defined by the size more than 5 centimeters or more than 3 tumors. If there is a macrovascular invasion or microvessel invasion, or there is a grade 3 or 4 histology. This was based on the IM 050 study. So we will discuss this study later in the slides. So if we look at the treatment algorithm, again the same thing. So prognosis depends upon the stage, and we need to characterize the patient. If we look at the advanced stage disease, basically in the advanced stage disease, the systemic therapies, they have a role. But if we look at the early, very early, or the intermediate stage, early and very early, clearly, it is the ablation, resection, ablation, transplant. And maybe this is the intermediate stage where we may have some role. So if we look at the hiatus 2007 to 2017, basically we had nothing. Multiple things was tried. This is in the metastatic and the recurrent setting. And we do have therapies for first line and second line. Unfortunately, adjuvant space, these things are lagging. So like in the previous first slide, I said the etiology. Is the etiology important? Because in adjuvant therapy options, if we look, there are options like antiviral therapies. So there have been studies to look at whether it makes a difference in terms of DFS and OS. Then there are two surprisingly Chinese medicine studies are also there, which were like literature is there. And we have local regional therapies in different combinations with IOs or with TKIs like sorafenib. So if we come to the adjuvant therapy for SCC in terms of antiviral therapy, so we know adjuvant antiviral therapy improves outcome after potentially curative treatment of HBV-related HCC. And for patients with HBV-related hepatocellular cancer, active hepatitis B-related liver disease, the use of nucleotide analogs is recommended. But whether these analogs will have benefit on oncological outcomes in resected patients who do not have active hepatitis or have a high viral load remain uncertain, and it remains to be confirmed in larger well-controlled trials before this is adopted. So coming to the role of adjuvant interferon, we use these in viral hepatitis patients, but again, its role as adjuvant therapy following complete resection is not established as yet. So then we come to the emerging role of immunotherapy. Yes, the role is very well defined and is still emerging in advanced recurrent metastatic setting, but we do not know in the adjuvant setting. So if we look at the BCLC staging, clearly BCLC-C, we have systemic therapy, but in this phase A, very clearly it is a local therapies. In B, BCLC-B intermediate stage, there are studies which are coming up. So in this chart, the same thing may be under investigation. We have different combinations, permutations of anti-angiogenics plus IOs in different formats, which the studies are ongoing in the early and intermediate stage. So the same thing in BCLC-B, we have a study, Tactics L, which was done with TACE plus lenvatinib, which is ongoing and we do not know. So this was the study schema. We will not go into the detail. So if these are the selected ICI studies, immune checkpoint inhibitor studies, along with TACE, which are ongoing. Important one is Emerald 1. Then we have Checkmate 7. So this is the study design, and these studies we will not go into the detail. So coming to the Emerald 1. So according to the press release, the study has met its primary endpoint and data presentation is awaited, but it was present in GI ASCO 24. So we have the results in the abridged form. So it was basically it was a study with patients with intermediate stage SCC ineligible for curative therapy. No prior taste of systemic therapy were randomized to 3 arms: TACE plus Durva, TACE plus Durva, and followed by Durva plus Bev and TACE plus placebo, and placebo was. So based on this, the Emerald 2 is going on. That is, this was for unresectable patient. Emerald 2 is for the patients who have gone curative intent treatment. So these was the results which were presented. So if we look at the arm with Durva Bev plus TACE had shown median PFS advantage as compared to placebo plus TACE, but there was no difference if compared with Durva plus TACE versus placebo plus TACE. There was no difference in terms of so this study, basically the response rates were better in the combination arm, but this was in the unresectable setting. So these are the ongoing studies in adjuvant setting. So basically we have Checkmate 9DX, which is nivolumab and phase 3 studies. Emerald 2 is Durva bevacizumab based on Emerald 1. Then we have Keynote 937, which is ongoing study. And we have I Am Brave 050 study, which is nivolumab atezolizumab study. So if we look at the studies, so atezolizumab was the I Am Brave 050 study, which we will talk about. This was the schema for I Am Brave 050. The patients with newly diagnosed SCC who were treated with curative resection or ablation, they were randomized. They all had Child-Pugh A, and 1 cycle of TACE was permitted. They were randomized to receive atezolizumab and versus active surveillance. So again, the crossover in the study was permitted on crossover. The primary endpoint was recurrence-free survival. So the same criteria which we have discussed earlier defined it as the high-risk patients which were enrolled into the study. So this was the recurrence-free survival of the study. Clearly, the curves separating early. However, in the long term, maybe after 2 years, they seem to merge together. So we do not know what does it mean. Maybe it is just delaying the recurrences, giving a better recurrence-free survival. So again, the same thing at 17.4 months, the patient who received adjuvant atezolizumab showed a statistically significant IRF assessed recurrence-free survival with active as compared to active surveillance. The treatment group showed a longer 12-month recurrence-free survival, 78% compared with 65% in the active surveillance group. So if we look at the OS is still immature. So maybe we will know with passage of time how did this study perform. Again, we need to know, though the advantage was there in terms of RFS, it came at a cost of toxicity. There was like significant toxicity was there as compared to the active surveillance. That point we should not miss. So are the results of IM Brave 050 practice changes? They are clinically important, but remains to be seen whether they will change our practice, because the data for OS is premature and long-term follow-up is needed. So based on Emerald 1, the Emerald 2 was taken up. So again, this is a study with patients who have high risk of recurrence after curative therapy. Curative therapy may mean surgery or local ablation, etc. Again, randomized into three arms, followed by the results of this will get maybe in near future. So again, the other studies which are going on with Nivo, Pembro, Camrelizumab plus apatinib and Durvalumab. Emerald, these are ongoing studies. So another important drug in the use of SCC is sorafenib. So we know the sorafenib is there in the advanced metastatic setting, but the adjuvant, the phase 3 studies, there are two studies in adjuvant, one study in adjuvant study, phase 3 studies there, we did not show benefit. And intermediate stage, we have with taste and post-test study, phase 2 studies are there. STORM was the study which was done in the adjuvant setting. So it was sorafenib as adjuvant treatment after surgical resection or local ablation. Patients who had undergone curative intent treatment, had Child-Pugh score of 5 to 7, were randomized to receive sorafenib versus placebo. The endpoints was RFS, OS, BACMA, etc. If we look at the study, the recurrence-free survival independent review committee, it was the curves are just Kaplan-Meier curves are overlapping, so did not show any benefit of sorafenib in the adjuvant setting. So again, these are the studies which are ongoing. ATACE, which is sorafenib with TACE, and SOURCE again with TACE. So maybe in coming days, we will get the updates from these studies to make us wiser. So coming to the ongoing and emerging therapies, we have new IO agents, we have CAR T cell therapies. So many studies are going on with these studies. So we have cell therapy in the form of um, uh, different studies again with cell therapy is going on. Targeted therapies we discussed earlier. Maybe there's a we need to investigate more of combination therapies, to which we need to move towards personalized medicines. And again, coming to adjuvant, we need to treat or address these patients quite early, maybe in the new adjuvant setting itself, so as to know and modify the microenvironment in coming days in some way. And again, novel drug development is required, maybe a different approach to the therapy. Most important thing in the treatment is the resistance mechanisms. If we can identify the resistance mechanisms, somehow maybe we will be able to better target our cancer cells to have better outcomes. So again, for which we need biomarkers, and again need to participate in clinical trials. So all these things remain a challenge in the future. We need to have patient-centered care, and multidisciplinary approach is the way forward. And I think I'll conclude here. We need to have more of biomarker-driven therapies. We need to have more understanding of the disease, and multidisciplinary treatment at this point of time, with combination of curative intent treatments, maybe IOs, maybe TKAs, is the way forward. Thank you very much for the patience.
Thank you, sir. Thank you for the excellent presentation. And any questions?
So thanks, Sumit, for this extensive review of literature. So coming to the practical point, I mean, you showed that this footnote, for patients who are at high risk of recurrence after resection, or who have more than 5 centimeter tumor, or more than 3 tumors with bad differentiation.
Yes, sir.
So such patients should you, or should we be considering for adjuvant atezo-bev?
So that was the, sir, I'm Brave 010050 study, sir. And
Right.
this time, sir, the authors concluded probably it is showing some benefit in terms of RFS, recurrence-free survival. But if we look at the curves, they seem to be merging at the end of nearly 20 months period. So the authors also think probably the benefit is there. Maybe it is not that it will like prevent, like in adjuvant setting in breast or in lung, but maybe it is just delaying the recurrence from happening, but not curative, sir. So at this point of time, probably I'll not be inclined to atezo-bev in these patients, sir. Probably I'll wait and watch.
Yeah, but then maybe it can be put across to the patient.
Yes, sir. It can be, yes, sir. But again, in this study, the toxicities were quite high, sir. So that again, we need to look into that from that point of view also. Yes, definitely it can be put across to the patient to decide.
And so this was one, of course, area that is where you've resected, and the
Yes, sir.
second is the area where you're looking at a TACE or tear where the cure
Yes,
is
sir.
not possible.
Yes,
So you have the Emerald One, and you have the tactics and the launch study.
yes,
So
sir.
do we routinely use TKIs, or we should start using durvalumab in such patients post TACE or tear?
Yes, sir. Sir, the last point, sir. Last line, sir.
No. So patients who are undergoing TACE and tear
Yeah.
and who are
And
not resectable.
yes, sir.
So I mean, do we
Yes, sir.
use TKI, or do we switch to durvalumab and
Putting them on lenvatinib at this point of time, sir.
so what do you think about the Emerald One?
Hello.
Hello.
Sir, I'm putting them on lenvatinib at this point of time, sir. Considering
So what
hello,
about Durva?
sir, Durva. No, sir. At this point of time, Durva plus Tremi, we will see, sir. But again, different toxicity profile for atezolizumab. Definitely IO combination. Maybe with coming days, sir. At this point of time, not used, not much experience. Need to learn more, sir.
Right. So I think, yeah, you're absolutely right. So we need to sort of wait for more data to evolve before we start using these. Certainly, lenvatinib is there for patients who have undergone
And,
TACE.
yes, sir. Just one point, sir. Maybe, sir, if we know how to sequence it properly, maybe if we know what is better, what is there after atezolizumab, if we have a better options, maybe we may consider it in the high risk adjuvant setting also.
So thank you very much. And I think we would love you to stay back for the panel.
Thank you, sir. Thank you, Sumit Goel, sir. And as we move forward to the last awaited session on panel discussion, which is sponsored by AstraZeneca, and to moderate the panel on optimal management of BTC in the new era, I would like to invite Dr. Sandeep Batra, who is Senior Consultant, Senior Director, Medical Oncology, Max Super Specialty Hospital, Delhi. And the panelists on board are Dr. Praveen Jain from Akash Healthcare, Delhi, Dr. Varun Goyal from RGCI, New Delhi, Dr. Aditya Sareen from Sir Gangaram Hospital, Dr. Ankur Nandan Vasne from Fortis Gurgaon, Dr. Raghav Seth from Sir Gangaram Hospital, and Dr. Dhir from Director and Head Department of Liver Transplant and Hepatobiliary Surgery, Sir Gangaram Hospital. So I would like to invite all the panelists and moderator to continue the panel discussion. Over to you, sir.
Yeah, thank you, Team Horizon. Thank you, Dr. Sham, for this opportunity. And let's continue from the hepatic part to the biliary part. And I have been asked to moderate a panel discussion on the optimal management of biliary tract cancers in the current era. As you would understand, it will be mostly involving a discussion more of the unresectable or metastatic disease, but it will not be complete unless until we dwell upon the diagnostic as well as the treatment for the early part of the disease. So we have in the panel very senior medical oncologist as well as gastroenterologist as well as liver transplant surgeon from various hospitals, including Sir Gangaram Hospital. So just the introduction slides, we all know the quantum of disease, which is biliary tract cancer. It is number 2 worldwide following Chile. And we have the second highest number of cases of all the biliary tract cancers, which includes both the intrahepatic, extrahepatic cholangiomas, as well as the gallbladder cancers. And despite the best possible treatment available till now, the outcome 5 years survival rate is a dismal less than 10%. And most of the times these cancers are diagnosed in advanced stages. And that's why the major part of the discussion may be on the metastatic or unresectable advanced cancers. And for reasons unknown, the incidence is continuously increasing over the last few years. maybe because of the migration of the population, or there is something in the environment or something in the diet which is gaining these things. And if you could see the same thing in the left side bar diagram, which shows a horizontal bar diagram. Following Chile, we have in the India, especially the northern part of the India, the maximum incidence of the biliary tract cancers, and much has been researched about the heavy water, the mountainous water, the H3, the soil, the radiations, but there is nothing conclusive per se which has concluded why we have in the northern part of India so much of higher incidence of the biliary tract cancers. So let me start with first the basics of the disease. So most of the times these patients would come, especially the early diseases, with symptoms like dysphagia or loss of weight, loss of appetite, and sometimes also with the jaundice, which is increasing, or sometimes with the other gastroenterological symptoms. So may I ask Dr. Raghav Seth, who is a consultant department of intervention radiology, how many times do you encounter such patients with the jaundice, in which you have to take a call about how to manage these patients further?
So, sir, good evening.
Good
So,
evening.
as far as caseload is concerned, sir, number of patients per month with presenting with obstructive jaundice in our setting would be approximately, in our hospital, 15 to 20 per month.
Okay.
That are presenting to our department, as in directly to our department. But
Okay. So, Dr. I will come back to you. I think there was some. Actually, I wanted to direct this question to the hepatologist with us. Sir, Dr. Dheer, many a times patients would come to you with these symptoms that are a mix of multiple upper abdominal organ symptoms. So, how many times you find that I would say unidentified symptoms or not leading somewhere to be the symptoms, the manifestations of a biliary tumor, biliary cancer, whether it is gallbladder or the cholangiocarcinomas? Is Dr.
So all greetings to the all esteemed panelists. In my surgical practice, you see, we generally get filtered patients.
Okay.
And it's mostly through our medical gastroenterology colleagues that the patient reach us. But if I were to talk about gallbladder cancer per se, 100% of them are symptomatic, and most of them are presenting to us with the jaundice. We have been lucky only in 10% patients where the GB cancer is infiltrating through the fundus, and we don't have any jaundice. And in terms of biliary tract cancers, which are not gallbladder cancers, and if they are distal cholangios, again, we will have them with symptoms. Majority of them, I would say. Only in intrahepatic cholangiocarcinoma, we'll have vague symptoms, which we have seen, where, one of my patients was diagnosed as pancreatitis, but she had a intrahepatic cholangiocarcinoma. So I think we cannot classify the entire biliary tract cancers as a similar one. Distal cholangio will present differently. Gallbladder cancer has a different presentation in our clinic. In our clinical setting, as I mentioned, most of them will have symptoms, and majority of them will have jaundice, and majority of them which reach us are, as we know, are unresectable.
Okay, thank you, Dr. Dheer. Dr. Sareen, I would like you to come in. You are from the same institute from which Dr. Dheer is there. So you are a large center for the gastroenterological diseases, and most of the times you will be getting the referrals from the gastro colleagues or the hepato colleagues for the patients who are recently diagnosed with advanced biliary cancers. So going by these ABCD 5 points, can you just tell us what is the caseload, what is the differentiation cholangios versus GBs, what is the usual socioeconomic status, if there is a trend, poor versus not so poor, and what is their typical performance status at presentation, and whether they are resectable or advanced? I think that question is already partly discussed by Dr. Seth and Dr. Dheer.
So yeah, I think I will start from the question number E, because most of us, we get a call, and majority of the time, I think most 70 to 75% of the time, then the patient is having, advanced metastatic disease, whether it may be because of the non-regional lymph node or one liver deposit. So, initially resectable and then, turning out to be an advanced case. But I think if I have to share between my experience over in our institute, it is to the tune of 70-75% presenting to us in the advanced stage, and for obvious reason, 20-25% of the patient is the resectable one, because they also are referred for adjuvant treatment. And coming back to the performance status and the population that we deal with and the nature of patients we are having, we are technically encountering every spectra of the PS, whether it's 0 or about to be 4. So most of them, they somewhere land into 1 or 2. I am yet to see a patient who says that doc, I'm absolutely fine. So I think most of them come to with the PS of 1 or 2. And socioeconomic status, yeah, mostly middle and low middle. And the B point, but about the GB and the cholangios, I think it is 80-85% that we are dealing with the GB cancer, and 10-15% only, cholangios. And the number wise as well, I think Raghav was spot on that, for the patients that we get, I think 10-15 cases, I think, yeah, we are handling that kind of a load. Yeah.
So, Dr. Varun, thank you, Sarit. Dr. Varun, you are also from a large volume center. Going by these points, we already heard what Dr. Sareen had to say, and Dr. Dheer already said, and Dr. Seth also mentioned. Is there any different perspective from these ABCD 5 points in which the presentation of the patients is there? Like if you have more number of patients, or you have a better or poorer performance status, or since all the patients, irrespective of their caste, creed, and financial status, come to you, do you see any pattern which is different from what our colleagues from Sir Gangaram Hospital have to?
No, sir. It's almost same. Caseload, same 15-20 patients per month. If you combine both, most of the time they GDC only. Loss of status mostly. PS, somewhat 2, around 2. And most of the time they are advanced only and not resectable. And it is around 80%, 90% advanced, 10-15% resectable. But most of the time we have to give some urgent treatment for that, and then we go for surgery.
Okay. So, Dr. Praveen and Dr. Ankur, I believe what the previous panelists have said, do you agree with that? If there is any point which you want to discuss out of these 5 points, we'll discuss, and then we quickly move on to the next part of the presentation. Dr. Praveen and Dr. Ankur?
Sir, I think cholangiocarcinoma, so we should not discuss it as a one disease, because the distal cholangiocarcinoma, so they present many a times in a resectable state, but most of the times the intrahepatic cholangiocarcinoma or the perihilar cholangiocarcinoma, they present with the unresectable state, and this is the practice. And one more pertinent point is that we get lot of GB cancer but less cholangio, and probably it is because that many of these patients who have liver metastasis, they are diagnosed as a MUO liver metastasis rather than cholangiocarcinoma. These are unknown primaries, so who have CK7 positivity, CK20 negativity, where we treat it as a upper aerodigestive or pancreatic or biliary primary on the basis of IHC, but we do not know the primary, and many of them, they have cholangiocarcinomas.
Okay, point well taken. So, I will come back to you, Dr. Dheer. Dr. Praveen raised a very pertinent point. Many a times these are cholangios which are mistaken as MUOs. So, although this question would have come later in the presentation, but I would like to know from you, what do you think with a disease confined to the liver, a cholangiocarcinoma, or for that matter, any confined localized extrahepatic cholangiocarcinoma, what is your best possible advice for treatment for some patients? Liver transplant versus only resection followed by some adjuvant treatments.
Sir, considering the fact that we treat patients, as Aditya said perfectly, most of our patients are coming from a middle to low socioeconomic status. If we have a resectable intrahepatic cholangiocarcinoma on imaging, we would like to go for resectability rather than offering transplant. Even for HCC, we struggle to offer transplant because so many things come in between. One is availability of donor, second is finances. It's not easy to fulfill the logistics of liver transplantation in our country, especially with the kind of socioeconomic status we deal in these patients. So if given an option, I have a resectable tumor, we my first preference is resection. We have done one LDLT for cholangiocarcinoma recently. Until now, he's doing well. We've not had an opportunity to strictly follow a protocol where we can offer them LT for cholangio. Being very honest and upfront, because most of them come in a state where we cannot strictly follow the Mayo protocol. For gallbladder cancers, which are locally advanced, I would like to tell you, we have become more aggressive. We are doing trisectionectomies uh, and even segmental duodenal resections if required so. And many of these patients, Dr. Sham Agarwal and Dr. Aditya are following in an adjuvant setting post-operatively. And we are seeing a fair good response in being aggressive surgically in these set of patients and being aggressive from a medical oncology standpoint post-surgery as well.
Okay, thank you. So just another question, Dr. Dheer, and probably that will be the finishing of the resectable diseases. Is there any cutoff of the bilirubin level when a patient who presents with a jaundice, obstructive jaundice, but otherwise has a localized disease? Go for
if I'm not doing a major liver resection, sir, then I go for a limit of 10. If I have a liver resection involved and I am worried about the future liver remnant, then I want the patient to be totally non-cholestatic, because I would not do a trisectionectomy where we have a 30% remnant and patient bilirubin is 5. No, I would not take that chance. So I have rather get them drained, if not by our medical gastroenterology colleagues. Raghav is there. They all know what we do. We try to get the bilirubin down, and then we go ahead for a major liver resection. As far as radical cholecystectomy is concerned, if it is truly obstructive jaundice, we like to treat them as cholangitis, and if not required, we not stent them. But to be honest, in our practice, most of them come through medical gastroenterologists, and most of them have been stented.
Fine. Thank you, Dr. So now we bring in Dr. Raghav, being an interventional radiologist. He is very helpful for us for managing the jaundice, especially the obstructive one. So, Dr. Raghav, what is your preferred approach about the management of obstructive jaundice? ERCP stenting versus a PTP stenting, or a mix of both?
So, sir, basically it depends on the type of block. So, if it is a type 1 block, or if it is a communicating type 2 block, that is both the systems right and left are communicating, then ERCP guided stenting would be better. And easily the stenting, if it is unresectable, stenting can also be done in the same setting, provided the patient is not in cholangitis. But if it is a higher level of block, type 2 or type 3A, 3B, in those cases, PTBD stenting will definitely be at a higher level than ERCP, because we can access multiple ducts percutaneously and then cross the tumor and then put the stents in the same setting or in a staged way.
Okay. Fine. And is there a definite percentage of patients who, despite all the interventional procedures, fail to respond to the drop in the bilirubin levels?
Yes, sir, absolutely. I would say 10 to 20% of the patients, despite radiologically complete drainage of the radicals, still the bilirubin is not decreasing to the desired level.
Okay, fine. Thank you, Dr. Seth. And Dr. Dee, one last question to you. What are the recurrence rate for the resected biliary tract cancers in your practice?
Sir, it's a very broad question, but we know we have despite the best treatment, resectability, we have a high recurrence what we face. So with the locally advanced gallbladder cancer, when we are dealing, we are seeing somewhere close to 60% recurrence in first 2 years. And in HCC, we've done fairly good. I have a lot of patients who have no recurrence for 5 years. Majority of them resectable HCC. This is I'm talking about non-cirrhotic.
Yeah.
In cholangiocarcinoma, again, if it's intrahepatic distal cholangio, very good prognosis we are getting in resectable. I would say around 20 In our data, probably 27, 28% recurrence. But for intrahepatic cholangio, which are large, we've had very high recurrence, close to 60% 2 years, 60 to 70%.
Yeah, I think we also have similar figures. I think we have tamed the HCCs better than the cholangio, and that's why there is so much of discussion about BTCs. So we have already discussed the role of a pathologist, gastroenterologist. These are the standard diagnostic, pathological, and radiological tests to.
Sir, I have one question if I can ask.
Okay, actually, it was my job. Anyhow, Dr. Parveen.
I'm not asking from your side, sir. So I just want to ask the surgeon side. So the liver ascites, does it make any difference in the curative surgery of the cholangiocarcinomas?
You mean ascites, of ascites?
So high-SAG ascites.
Okay.
I mean to say portal hypertension leading to ascites.
Absolutely, sir. If you have a patient who is presenting with ascites, that means there is definite high degree of liver damage, whether the patient is background cirrhotic and you would not like to take a child B for a major liver resection, the risk of decompensating him further is extremely high. I would use caution to operate on such patients who are presenting with ascites. I would like to actually evaluate them for malignant cells, with their ascites, and only then go from a patient who has portal hypertension. Thrombocytopenia is an absolute no for surgical resection, in my opinion. The risk of decompensation and managing these patients post-op is extremely, extremely difficult in our setting. Most of these patients are paying out of pocket. It just prolongs the ICU stay and
yeah, please, sir.
It prolongs the ICU stay and overall morbidity.
Fine, sir. Fine.
So if a patient presents to me with ascites, I would actually refer him back to the medical gastroenterologist for optimization of his background liver disease, portal hypertension, and treat him like that. And then it's a discussion between the medical gastroenterologist and the medical oncologist, how aggressive would they like to deal with such patients in whatever treatment. I would totally avoid any surgical treatment in these.
I think fine, sir. I think that answers your question, Dr. Praveen. And let's shift the gears. Now we already know that despite a very well done resection, despite all the adjuvant treatments that were given, there is quite a significant majority of the BTCs, they come back. And when they come back with a vengeance. And many a times we need the help of the gastroenterologist, interventional radiologist to take care of the obstructive jaundice. And once their performance status and the LFTs improve, we have to offer them some treatment. So we start with Dr. Ankur. So do you, besides the normal biopsy IHCs, do any molecular marker testing on the biopsies upfront, or you reserve it for a later use?
So upfront I used to test HER2/neu.
Upfront you?
HER2/neu.
HER2/neu. So only HER2/neu you are doing. Okay. So
in selected cases, I opt for PDL1 if they ask me what is the prognosis. I told them that for treatment, this is not indicated. But if they ask what is the role of immunotherapy, then in selected cases, I opt for PDL1 so that I explain that what is the prognosis with the use of immunotherapy for these patients.
Okay. So, Dr. Sareen, do you follow the similar approach, or you have some different approach at your clinical practice in your hospital? You do the selective markers, or you send them for a wider panel to start with?
So I think depending upon patients' financial viability, and most of them, so I do get 2 IHC markers by MMR and MMR proteins by IHC and HER2/neu. And if patient is affording, I send the other block for the NGS straight away, because it saves you the time, and definitely you get the information whenever the patient progresses on your line of the treatment, or you can add or subtract your molecular targets as per the NGS as well. But yeah, most of our patients are going at least MMR protein by IHC and HER2/neu by IHC.
Fine. I think even we follow the similar approach. Dr. Varun, your center also is a high volume center seeing these patients. So do you do a selective marker testing, molecular marker, or you send a wider panel? I think your lab is equipped with that for a wider NGS panel.
Yes, sir. So we counsel all of our patients to do wider panel. we have prepared one panel for especially for the BTC patients and pancreatic patients. So but at least HER2 have to be done, and PD-L1 as
I
my
think we
other
unanimously
panelists.
agree hard. Yeah.
Yes.
So
PD-L1 may or may not be, because in any case we are going to treat with IO like Ruba. So, but we counsel at least. But because of the financial reasons, maybe 50% or less than those patients only will go for NGS.
Okay, so Dr. Parveen, there was much of discussion about the IDH1 mutations or substitutions. Do you see that in your clinical practice? Because that can only be seen if you had sent a wider NGS panel.
So, sir, what I have started is that during the initial HPE only we order the IHC. I get HER2 testing done by IHC. We do not have MMR IHC panels with us. So at the same time, I also counsel the patient for NGS, for broader NGS panel. So nowadays, so it is very cost effective. So we are getting the NGS panels at 25,000 rupees only. And there are a lot of tissue agnostic or site agnostic markers are there, which we can utilize in the subsequent lines. So I always try to do that, and almost 60 to 70% of the patient they comply with the NGS orders. And sir, practically, I have not seen a single IDH mutation positive cholangio or GB cancer. So, sir, we most often we see the GB cancer, and the rate of IDH, I think it is lesser in the GB cancer as compared to the cholangiocarcinomas, and probably this is the reason why we don't see that often.
Okay. So, although the literature mentions about 15 to 25% rate of IDH mutation, till now I've seen one patient in my clinical practice and one patient Dr. Vineet Gupta shared with me. So these are the two patients I know. Maybe since most of us are not sending a wider panel NGS, or if we are sending, it's a limited panel NGS, so probably these mutations are missed. However, since it is a target for which we have a oral targeted treatment, this is something we should start doing in our practice, and maybe the pickup rate is higher.
Sir, but one problem is with IDH, like we have seen 2-3 patients, but drug is not available, and if we want to import it, is very, very costly. It's around 17, 18 lakhs per month if
So
we try to import. That is the problem.
most of the oncological drugs which are unique and patented are costly, Dr. Varun. But thing is that if it is recommended as per the guidelines, and if the drug can be brought with the due permissions, then probably it is worth doing this test. I'm telling you because a patient of mine with a CAGV whose daughter was doing the molecular analysis in US, she upfront sent a wider panel. Rather, they took the sample to US to do it and found out they saw IDH1 mutation positive. However, despite her inclination to start in the first time for which the drug approval is not there, we started with typical GemCis plus Ruba will be coming to that combination. And she had a good about 10 to 12 months of disease-free survival. And then on progression, we used this drug. What happened, I think we will discuss in person. But probably, if we do it, then only we know it. And as far as availability is concerned, who knows that the availability may not be the affordability may not be a problem for the patient. I do agree with what you are saying. I do consider. So although in the HCC, we are quite adept on doing the local regional therapies, as a medical oncologist, first Dr. Praveen or Dr. Ankur or Varun or Dr. Sareen can answer that. Do you ever use any local regional therapy? And then we move back to our interventional radiology colleague, that do they get any referrals for any intervention for local regional therapy in advanced biliary cancers? Besides the drainage part, routine drainage.
Yes, we have done local regional therapy in the form of mostly it is targeted radiation. After systemic treatment, if good response is there, then especially for intrahepatic IOCC, some targeted radiation have been done. And few cholangio, there are not a single site, maybe multiple in the liver, mainly liver disease. And we have tried TACE also with good results. But all these local therapy after systemic therapy, and if there is any response.
So, Doctor, say, do you get referrals for doing TACE in the cholangios?
Yes, sir. As rightly said, if we compare HCC and biliary, the role of local regional therapy is very limited in the biliary tract cancers. But for cholangiocarcinoma, we have got very few references for TACE. and we have even done TACE. So the response till now, the follow-up is good. But overall, if we go by the literature, TACE and TARE, the literature, they are saying that it is the overall survival increases a bit. And one of the latest studies, they have proven TARE to be superior to TACE, of course, with financial problem.
Fine, Dr.
We have also used in one patient with a localized recurrence of cholangiocarcinoma.
Okay, so I think loco-regional treatment wherever possible, especially when with the limited choices are there, we are resorting to using. Thanks, Dr. Dr. Ankur, there are 5-6 combinations over there for the advanced biliary tract cancers. You know, all of these can be used, doublet or a triplet or a single if the patient PS is poor. So what out of these is your preferred combination, or if there is any other combination that you use of, and what is the trial behind that?
If performance readiness is well preserved,
there is no problem.
And the financial indication is not, I prefer to use option number 6 as a first choice.
Option number 6, Durva plus Gemcis. And what if patient is not eligible for a cisplatin because of the morbidity, renal dysfunction?
And then in case of morbidity, I prefer JAM. So this
okay.
Because I can think that definitely if not fit for cisplatin, then definitely he will not be fit for oncology. Then I use JAM cap.
JAM cap. Okay. So my medical oncology colleagues, Dr. Varun, Dr. Praveen, Dr. Vankur, and Dr. Sareen. There are two conditions. One, finance is not a bar. Second, the type of constraints we have financial. So what is the go-to treatment in both the situation? First, no bar finances. Second, finances are barred. So does the combination change in the presence or absence of the financial status?
Sir, gem platinum, I may say, either cis or carb. We usually don't use Oxali in the first line because we usually prefer Folfox in the second line. That may be institutional preference. And we have seen many patients with gem Oxali in the first line, that is fine. Obviously, wherever possible, financially Durva to be added there.
Fine. Dr. Praveen?
Sir, I think the practice is same. So if finances, so they are not an issue. So GEMS is Durva as per the Topaz 1 trial. But if finances are a bit of concern, so then gemcitabine cisplatin only.
I think since 2010, when the ABC2 trial came in, GEM plus cisplatin became the standard of care. Subsequently, platinum ineligibility, especially the cisplatin ineligibility, led to multiple trials with the different oxaliplatin, carboplatin, so on and so forth. And no one was able to beat GEMCIS. So they were always compared equivalent. And we have trial from TMS, trial from AIMS, and trial from other centers, which showed that any platinum, whether it is cisplatin or oxaliplatin, has almost similar outcome as far as PFS and OS is concerned. So all of us agree that if finances are not a bar, addition of immunotherapy to the gemcitabine cisplatin based on the Topaz trial improves the outcomes. Now, I would request you to focus on, let's move on these points. I think they are not very pertinent to this. So we'll coming to the immunotherapy in the first line. So Topaz 1 trial, we already know that the population was the similar population that we usually get in our practice, and the patients were given gemcitabine cisplatin 8 cycles. Cisplatin was lower dose, 25 milligram per meter square. So 8 cycles, and subsequently durvalumab, which was given along with chemotherapy, was given as a maintenance treatment, flat dose 1500 milligram every 4 weekly, and this was continued for 2 years. And so you can see the figures, the population, the patient demographics were same, MSI status, PDL1 status, previous treatment status, which was untreated, was the same. And you see the curves of the survival, which was sustained for more than 2 years of data that we have. Now, for a disease which did not have anything significant for almost about 12 years, from 2010 to 2022, when we got the approval for this drug as a combination, I think even though the number of weeks or months this drug durvalumab has given excess of what the GEMCIS was doing, since it is a durable thing, so all of us, based on this one trial, are comfortable using this drug in combination. So, so these are the OS and the PFS we have all seen in the previous practices. So, Dr. Varun, we start with you. Any apprehensions for using this combination unless until there is no contraindication for the treatment? Gemcitabine, cisplatin.
No, sir.
So
Good
wherever
tolerance. If there is no absolute contraindication,
we are going
we
to get this
would
one.
like to do this. Yeah, we would
Okay.
like to do this.
What about any other immunotherapy drugs in place of durvalumab?
Pembro, there is data. We can use that, but till now, more inclined for the Durva because we were also part of the Topaz trial, and 2 3 patients we have recruited. So good responses we have seen. Few of our patients have gone to metabolic CR, although recurred after a few months, but still. So there is no IRD like we can't manage. Most of the time these are grade 1 or 2 and easily manageable. So no issue.
What
If
is the
there is no absolute contraindication.
benefit in the form of OS and PFS we are getting with the addition of durvalumab?
As you already discussed that it is obviously in few weeks or months only, but few of patients. That's why there is more need for selective biomarkers. We are nowadays giving to every patient, but some patients are doing very good and some patients are not. But yeah, there is statistically significant benefit.
Fine. Dr. Ankur, if we go by the trial, Topaz 1 trial, so we had OFS, PFS, we had OS, we had response rate and the duration of response. Which particular thing excites you the most? The OS, which is documented, which is better as compared to Gemcis alone, or the
Definitely, sir, OS is a better parameter, but there is only one thing that I would like to note. In Topaz trial, majority of patients were cholangiocarcinoma. In our clinical practice, we used to get majority patients with gallbladder. So that have an inferior outcome. And what I know that what the real world data which was reported from India had a marginally inferior rate data of OS.
Okay, so real world practice think that GBs do not perform as well as the cholangiomas do.
As well as the cholangio.
Even if they are clubbed as a similar biliary tract cancer, there is a difference in the biology that makes a difference in the response and outcome to gallbladder versus cholangiocarcinomas. Is that understanding correct, Ankur?
Yes, sir.
Okay, so Dr. Parveen, we come to you. Although this question was answered by Dr. Varun that durvalumab versus pembrolizumab, you can combine both because data is there for both. The Topaz 1 trial had only the continuation of durvalumab for after the completion of 8 cycles of chemotherapy. In contrast, the Keynote trial, which used pembrolizumab, had the additional gemcitabine continued with the durvalumab for as long as possible, and despite the with the pembrolizumab, and despite the continuation of active chemotherapy arm as a maintenance and the active pembrolizumab as a maintenance, if you see, although it's not wise to do the cross trial comparison, the OS was similar, difference in the OS 1.56 months, PFS was similar, 1.8 months, response rate was similar, duration of response was similar. So what do you think that it is the active gemcitabine which was working, or it is the pembrolizumab which was working, or it is a combination which failed to surpass the benefit that durvalumab was able to give?
Sir, I think with durvalumab, so it was the durable immune response which did the magic. So if we look at the Kaplan-Meier curve post 6 months, so there was widening of the curve. And in fact, if we look at 2 years data, so 25% versus 10%, so the difference at 6 months and the difference at 2 years, so that is huge. So I think it is the durable immune response, so which is more active in this trial. So looking at the Keynote 966 data, I think because the control arm had gemcitabine as a SOC arm, so and gemcitabine was continued. So probably that was the reason that benefit which was seen with the Durva, so that was not seen in that trial.
Okay. So, Dr. Sareen, what about the immune-related adverse events? Do you find immune-related adverse events with durvalumab was similar to the class effect with the other immuno-oncology drugs, or it is somewhat better or worse than those?
I think if we are to talk about real world practice, I think it's a fairly reasonable combination, and I'm yet to encounter any major toxicity. Though few of my patients are currently on maintenance Durva, maybe once we get those kind of side effects, I'll be better able to tell you. But touch wood, for the timing, I have not experienced anything. So, I was wondering because, I had one case today and it was quite a strange phenomena that patient was having a metastatic CAGB and patient was also having retinitis pigmentosa. And for that, she had undergone the bilateral corneal transplant. So that was the conjecture point. So I was just, anybody can, answer that. Does that warrant exclusion of Durva, or we can still use Durva in this particular setting with the patient who has undergone bilateral corneal transplant?
But
And
she's
they are also again, supposed to, undergo because her both the cornea is going blank again.
so she's on immunosuppressive drugs, if I understand correctly.
No,
She's got
I
corneal.
don't know. I don't think so. For corneal transplant, they don't really require immunosuppressant.
Because per se for the other organ transplant, I'm not aware about
Yeah.
cornea. That's a strict
Yeah.
contraindication. I
Exactly. So
think same analogy will apply to this transplant as well, because the moment you activate the immune system, there is a real possibility that foreign tissues may be identified as foreign, which were till now suppressed, and then you can have rejection. I think Dr. Sham Agar
exactly.
has the maximum experience about using these drugs. May I request Dr. Sham to have his opinion about the unique situation that Dr. Sareen has told us, bilateral corneal transplant and advanced TB cancer, whether or not to use durvalumab. Is Shamsa there?
Yeah, so I think the transplant should be a contraindication, but I think one can look into the literature because graft rejection for cornea does take place. That would require, steroids and all. So therefore, I mean, unless we find out from the literature, I think it should be a contra, but I think we need to check.
I think I agree with you, sir, because if we know, although not everything is logic in oncology as well as the IU drugs, but if there is a foreign tissue in the form of transplanted tissue, with the risk of important organs like eyes, visual acuity is gone. So I would be steering clear of the IU drug at present, because even if I use the IU, I know I am increasing the survival by few weeks to few months. So making a person blind with using a drug which is only going to improve survival to some extent, I will not be very comfortable. Although once you feed the first line, second line, if there is an option of single agent IU and I am pressed against the wall, I may use it with a word of caution that be prepared that there may be a decreased visual acuity or blindness. I think Dr. Aditya would have a direct answer to that.
And can I request, another issue?
Yes, sir.
Everybody said that they are doing HER2/neu testing for their patients with biliary tract. So if you get, and you're getting it upfront, and if you get a HER2/neu positivity on, say, IHC3 plus or FISH positivity, then does that alter your sequence of drugs to be used in this patient?
So if I have to treat such a patient, I will add the anti-HER2 treatment to the ongoing protocol. Even if it is GEM plus CIS plus Durva, I will add on to anti-HER2 therapy. So I had a similar patient. So quite interestingly, it was after the failure of the first line that HER2 were ordered and HER2 was found to be positive. And since patient did not have finances for the immunotherapy, so we did not have a choice to use the same thing. So we went for a second line combination with the anti-HER2 targeted therapy. But if a patient would have come in the first line with a HER2 overexpression, I would use the trastuzumab in addition to what I'm going to offer this patient. I think Dr. Sareen, Dr. Praveen, Dr. Varun, and Dr. Ankur can also have their opinions.
Sir,
Yes, sir.
there is, I think, a biomarker evaluation which was done for either Topaz trial or the phase 2 trial of Gemcis Durva, and it was seen that only HER2 was the marker which, if amplified, so the benefit of Durva was not there. Other than HER2, so any other biomarker, so be it KRAS, be it BRAF, FGFR2, IDH, so the benefit of Durva was there. So I think you are absolutely right. So if HER2 is positive, we should be inclined toward using HER2-directed therapy rather than durvalumab.
Fine.
So shall we use,
Sir,
single trastuzumab or a combination of trastu with PER2?
I think Trastu and
because you have the approval of Trastu with Pertu in subsequent lines. But if you get that kind of a scenario and the finances are obviously not an issue, would someone be, shall we add FASCO to it?
I think that will add a lot of toxicity to the treatment. So I will first use one anti-HER2, and then if that fails, I will move to something like TDXT with fastest
Yes,
FSC.
that will be better.
Yeah.
So I will concur, sir.
I had to
We will do
agree that
Jansis
would be better.
Durva.
And I have
Jansis
used
Durva and
trastuzumab in some patients of metastatic gallbladder cancer, and I have seen good response. I have not combined it with durvalumab till now.
Fine. I think with this, I would thank all of you for your time, and I would thank Shamagal for this opportunity and Tarun and his team for this thing. And over to Dr. Shamagal for his kind comments and closing.
So thank you so very much, Dr. Sandeep sir, and all the esteemed panelists for such a wonderful discussion. Dr. Sham sir, final words from you. I think the entire sessions went very well. A lot of thought-provoking ideas, suggestions, discussions on the clinical pathway. So all yours, sir. If you can just give your insights and inputs, and then we close the meeting, sir.
So thank you, Sandeep, and all the panelists, Dr. Dheer, Dr. Varun, Dr. Ankur, Aditya, and all the faculty who joined us on both the days. Really, I think we did have a lot of takeaways from these 2 days of discussions. So basically, telling us that there is so much happening in every organ in terms of evolution of treatment, whether it is targeted therapy, whether it is immunotherapy, is some kind of surgical intervention or interventional radiologist, as Raghav was pointing out. So I think there's always a takeaway from these discussions, and in oncology particularly, we have stage migration of the immune checkpoint inhibitors, as you saw in urothelial cancers, where they were first used in the metastatic disease and now coming in the first line and moving in the in the maintenance setting. So I think we really need to organize these meetings often, and so that we learn from each other and from this multidisciplinary team approach where everybody contributes, so we all learn. And so I think we look forward to meeting each other on another platform or another webinar or a physical meeting. So with this, I do thank Horizon, Tarun, Gitika, Abhimanyu, and the team for really putting this, and all the delegates, who spent their time, Dr. Sekar, Dr. Jovita, and others who attended on both the days. So I think great. I think so. Thanks, and over to you, Tarun, for your last comment. Thanks to your team for this meeting.
Yeah. So thank you so much. I think the 2 days have been wonderful. And Dr. Sham sir, thanks for giving this opportunity. We look forward for many more, conferences like this. And with this, we like to, with your permission, close the meeting. So good night, everyone, from our side, from the organizing teams, on behalf of Gitika, Abhimanyu, and everyone from out here. Thank you. Good night. Stay safe and stay blessed till we meet next again.